Thanks, Mary, for the kind introductions, and thanks, Alessandro and Serge, for the invitation to this very nice and important meeting. So unfortunately, you gave me only 20 minutes, so I have to speed up, to give you an overview. So what is the status and timing of transplantation in myelofibrosis? So I will start with the first slide. This is a slide just showing two things. One is, these are the transplant data for myelofibrosis in Europe from 2002 to now 2014. So what you can see, there's a steady increase in the numbers of transplantations. So in 2014, we have about 400 in Europe, but the same holds true for CIBMTR. But interestingly, so when Ruxo was introduced by the EMEA in 2012, so 2012-13, you can see here, this was not like Gleevec. So that means, in other words, despite the having approved drugs for myelofibrosis like Ruxolitinib, the numbers are steadily increasing. And I show you how. So still, we have to deal with what patients are the best candidates for transplantation, or when we should do the transplant in patients with myelofibrosis. Because as you know, and as you've heard at this meeting, is that there's a very heterogeneous group of patients with different outcome. So, and irrespectively of the molecular, so the most clinical used score is the DIPSS score, and you have these risk factors like age, constitutional symptoms, anemia, leukocytosis, and peripheral blast count. And you can have 4 groups, and you can see the survival difference between 80% or 90% up to only 2 years with the median survival. So what we did actually, when we looked to transplant data, and these are data from the Fred Hutchinson Cancer Center, and they looked for the disease-specific DIPSS score at time of transplantation. But there you can also see nicely that if you have low-risk patients, the survival is more than 80%. If you transplant patient with high-risk disease, the survival is about 50%. So therefore, what we did actually, and this is a statistical model, so we did with Francesco Passamonti, so we looked for the patient who were in his database and received a non-transplant approach. This is in the blue one, in the green one here. And we looked for a transplant patient. You can see this was the red one, and you can nicely see that the transplant patient were mainly less than 65 years of age. So in this cohort, we restricted our analysis in more than 600 patients to only those who were less than 65 years of age. So we ended up with about 438 patients which were analyzed regarding the so-called decision-making analysis. So this is the so-called left truncation method, so without going too much into details. So what we found is actually if patient has a low risk, the hazard ratio was more than 5 for the transplant. In other words, a low-risk patient should not receive the transplant upfront, so the non-transplant approach was in favor. If you look to intermediate 1 risk disease, so there is a slightly in favor for non-transplant, but this was not significant. Whereas for intermediate 2 and high-risk patient, the hazard ratio was less than 1, so was significantly in favor for performing the transplant. So actually, therefore, if you look to this survival curve, you can see for low-risk patient, non-transplant approach is in favor. If you look to intermediate 1, you can see there is a higher risk of dying in the early phase using the transplant. But you can see also that after here, this is a long period, so it's 15 years. So after 15 years, these curves began to cross because there was no further relapse for the transplant. But if you look to intermediate and high, intermediate 2 and high, you can see significant benefit for the transplant. So therefore, what we did within the European Leukemia Net and within EBMT, if there is no randomized trial, if there is really no evidence-based by randomized studies, so we did a so-called consensus with different methodologies. And what we decided then, and this was published recently in this consensus with a lot of experts from the US and from Europe, so patients with intermediate 2 and high risk according IPSS, DIPSS or DIPSS plus, and age less than 70 years of age, they should be considered as potential candidates for the transplant. Whereas intermediate 1 patient, age less than 65, should be considered as transplant candidate only if they have other risk factors like transfusion-dependent anemia, a higher number of circulating blasts, or adverse cytogenetics. Whereas low-risk patients should not be considered as transplant candidates, but they should be monitored very closely to evaluate for transplant when the disease progression occurs. So this is quite reasonable, and this is actually what we do today. However, as you heard nicely this morning by the Italian, by Giuliana, is the impact of molecular mutation, which comes now more and more into clinic. And you have heard that the CAL, from the so-called driver mutation, CAL reticulin is in favor in contrast to JAK and the MPL, and this has been shown by different groups. And you have also heard this morning that the specific mutation, especially mutation in the epigenetic like AXS1, EZH2, but also splicing mutation like SISF2, they also influenced outcome, and you can see here in the hazard ratio, and this led to a more molecular-based risk classification. So what we did is actually we looked for those patients who received the transplant in our institution, and we combined it with another institution in Germany. So we had more than 160 patients where we screened this for the so-called driver mutations, and you can see the majority has JAK mutated, but the CAL mutation was 20%, MIPSS 4%, and so-called triple negative was about 16%. So this reflects also the common molecular markers you can find also in the non-transplant setting. Then we looked for the other mutations by next-generation sequencing. You can see the most frequent mutation was the AXS1 with about 30%, followed by splicing mutation like SSF2 with about 10%, or TET also with 10%. So we could see that these mutations were actually in line what we can see also in the non-transplant setting. So here you can see, so these were the driver mutation, and you can see all the other mutations are well distributed, so there was no specific correlation between JAK mutated and additional mutation, or CAL mutated and additional mutation, or MPL mutation and additional mutations. So interestingly, when we look for progression-free survival, and this is a univariate analysis, so we can find that age, more advanced disease like secondary leukemia to chronic phase, or higher DIPS, intermediate 2, and high risk versus low and intermediate 1, they were a significant factor for a worse progression-free survival, but this was known from other studies. As well, if you have a mismatched donor to survive, the progression-free survival was also reduced. So regarding the molecular markers, so what we could find is actually that the JAK positivity, U2AF1, AXL1, IDH2, and DMT3A were all significant factors for a worse progression-free survival, while the CAL mutation was actually a significant factor for improved progression-free survival. However, this was only in the univariate analysis, and interestingly in this study, so we could not find an impact for other mutations, especially like EZH2, which is also considered to be a worse prognostic factor in the non-transplant setting, and also in this category, triple negative was not significant in this study. So, but at the end, it's important to have this so-called multivariate analysis, so to look which of these molecular mutations are an independent risk factor for the outcome after stem cell transplantation. So here you have non-relapse mortality, relapse. These are both the factors for treatment failure, progression-free survival, and overall survival. So when we look only to the progression-free survival and overall survival, so we can find those factors which are already known. This is age, so older patients have a worse progression-free and overall survival. So we've looked to other clinical factors like more advanced disease, like DIP high and intermediate, resulted also in worse progression-free and overall survival. HLA mismatch resulted in worse progression-free survival. But when we look to the specific mutations, so we ended up with only 3 mutations. So one was the IDH2 mutation, which has a significant impact on the worst progression-free survival, but not on overall survival. AXSL mutation has a worse progression-free survival because of a higher risk of relapse. But the only mutation which influenced the overall survival was actually the CAL reticulin mutated. So these patients have a better progression-free survival and better overall survival, and this was due mainly to less therapy-related mortality. So here you can see the corresponding figures. So the CAL mutated patients have a progression-free survival here at 5 years of about 75%. And the overall survival was also at 5 years is nearly 80%, in contrast to those who were CAL mutated or were not CAL mutated. So interestingly, as you have heard also this morning regarding the CAL mutation, you can distinguish between so-called CALR type 1 and CALR type 2, and this is a sub-analysis, and you can see regarding the transplant, it's independently whether you have CALR mutation 1 and 2, all have actually a very good survival, about 80% after 5 years, so independent of the type of mutation, but also independent of the additional mutations. So if the CALR mutation patient has another mutation, like the XL1 mutation, for instance, it doesn't influence the outcome, so all had an excellent survival. So this you have seen this morning. So this was done by Alessandra Vanucci and presented at ASH last year or the day before last year. And this is the so-called MIPSS score, including clinical data as well as molecular data, so triple negativity, ACSL1 and SRSF2 mutations. And what we did, actually, we looked at whether this can be transferred also in the transplant setting. So we classified MIPSS 0 to 1 point in 32 patients, 1.5 to 2 points in 86 patients, and more than 3 points in 49 patients. So interestingly, they have seen this slide before. You can distinguish very nicely according to this MIPSS patient with a survival more than 75%, and those who have MIPSS high have a survival of only 32%. So therefore, the so-called consensus, so this is a consensus in 2015 from the European Leukemia Net and EBMT, has following consensus. So also the use of molecular risk classification for identification of candidates for allo-SCT among intermediate 1 patients deserves clinical validation. Patients with intermediate 1 category who are triple negative or are ACSL1 positive should be considered for allogeneic stem cell transplant. So independently of this so-called prognostic factor of molecular marker, how can we use this molecular marker in the transplant setting? So as you know from other transplant settings like acute myeloid leukemia or especially acute lymphoblastic leukemia, being in minimal residual disease status is a risk factor for relapse. So what we did, we looked in more than 150 patients who received the transplant for primary, post-ET, post-VV myelofibrosis, or some patients also transformed to secondary leukemia. So we looked specifically for the so-called driver mutation, and you can see in more than 80% you can have one of these mutations, 13 were triple negative. And in those who were positive for JAK, MPL, and CALR, we developed highly sensitive PCR technique to look for minimal residual disease. And more recently, other methods like so-called digital PCR is a very nicely method to look very nicely for a high sensitivity and also specificity. So we screened all these patients after transplant on day 100 and day 180 post-transplant. And what you can nicely see on day 100, you can see those who are negative independently which kind of mutation they have. So they have a very low risk of developing clinical relapse in the follow-up, while those who were positive at day 100, so the risk of having clinical relapse during the further course is about 50% and even a bit more. And if you look to day 180, it becomes more strikingly that then those who are negative, so that you can see the risk of relapse is quite low, it's below 10%, but those who are positive, the risk of relapse, of clinical relapse in the further course is more than 60%. So this is not just academical, it has also clinical implications, because if you transplant, you have a new immune system, and what we can do is we can harness this by so-called donor T-cell infusions. Yeah? And this is a small series which we did in our institutions, where we give this donor lymphocyte infusion in patients who have the clinical relapse and in those who have only a molecular relapse or persistent molecular disease after transplant. So we call this preemptive DLI. And interestingly, if you give this DLI in the salvage, you can achieve in nearly half of the patient, again, a molecular remission. However, you need more T cells, you need a higher dose of T cells, and this is associated with a higher risk of graft versus host disease, which is a major complication after stem cell. If you use it preemptively, we need only very low dose T cells, so we don't have any GvHD, and we have a high success rate of achieving, again, a molecular remission. So to prevent relapse and to include also is because you heard a lot of Ruxolitinib and other JAK inhibitors. So how can we combine, or how can we now deal with patients when we use Ruxo or transplant? And actually we have, in my opinion, we have 4 clinical questions which has to be addressed either now or in the future. One is when we should select patient for Ruxo and allo transplant. So we are currently performing a German trial where we randomized according to donor availability in older patients when they have a donor they received after Ruxo induction and allo transplant, and those who have no donor received Ruxo until progression disease. So this is an ongoing study, so we cannot answer this so far. Most important nowadays for us in the daily clinical practice is, so if Ruxo is used, can it be used as a bridging to allo transplant? And if allo is performed, when should we do the allo transplant? When we have the best response, or can we wait until Ruxo has failed? And what about Ruxo post-transplant? So when we look to bridging, so there are a couple of studies with a number of patients, so the numbers are quite low, but you can see in nearly all of these patients, you can see the therapy-related mortality is acceptable, GvHD is acceptable, so the risk of so-called rebound phenomenon, as you said, is quite low. The only study was a French random prospective study. They observed 2 deaths to GvHD and observed also some toxicity, cardiac toxicity, and so-called tumor lysis syndrome. So this study was on hold, but is now ongoing because they changed the tapering of the Ruxolitinib. In most of these studies, the Ruxo was tapered and was stopped at time of conditioning regimen. So therefore, in 2015, the recommendation from the EBMT, European Leukemia Net Consensus, was that the JAK inhibitor is indicated in patients with symptomatic spleen and constitutional symptoms. So the drug has to be initiated at least 2 months before transplantation and should be titrated to the maximum tolerated dose. A careful weaning starting 5 to 7 days prior to conditioning should occur in an attempt to avoid rebound phenomenon, with the drug stopping just the day before conditioning. So how should we stop, or when should we go for Ruxo? And interestingly, in our small study, we observed only a very good survival in patients who received the transplant if they responded best to Ruxo. And this is a more recent study, it's also published, it was presented at EHA last year. And this is from the CIBMTR group, actually. They collect a lot of patients from the US who received transplant and had a history of prior Ruxolitinib treatment. Then interestingly, this is the survival curve, the group A, 22 patients who received the transplant when they have responded to Ruxo very good with a 50% reduction in spleen size and a complete resolution of the spleen size if there was less than 10 centimeters. So best response to Ruxo, go immediately to transplant, has a survival more than 90%. However, if you do the transplant only in stable disease or the spleen response does not meet the criteria of group A, or you have a new onset, or you have progressive disease, or you lost response to Ruxo, you can see the survival becomes worse. And it is worse if you do the transplant if patient has already progressed to leukemic transformation. So at least if it is not a randomized trial, it's suggested if there is a patient with a clear indication for transplant and he is pretreated with Ruxo, the best option seems to be to do the transplant in patient when they responded well to Ruxo and not wait until patient failure to the Ruxo, which is sometimes a bit difficult because patients feel very good and they ask the physician, shall we really go to the transplant because they are in a very good shape. So last, I will give you some ideas about using Ruxo post-transplant. So interestingly, when we used Ruxo post-transplant, and this is in line with the COMFORT-1 and COMFORT-2 study, so Ruxo is not targeting the malignant clone. So if you have a relapse patient, you can see this is a chimerism. So usually they have only mixed chimerism, but in all of these patients, the chimerism goes down. It is not going up. And I can show you the same data for other mutations, so for CALR, for JAK. So the mutation is not be cleared if you use Ruxo alone post-transplant. But it's helpful to control symptomatic disease like constitutional symptoms or spleen size. More interesting is probably because the JAK2 or JAK2 inhibition is also a quite immunosuppressive drug. And you have heard nicely from Mary about the the infectious risk. And in the preclinical model, the Ruxo is really reducing not only T cells, it's also reducing the function of dendritic cells and NK cells. And this is done from a group in Freiburg. So they used the Ruxo first in mice, but then in patients who were steroid refractory, and you can see that they have a nice resolution of the severe acute GvHD of the skin, and here you can see the GvHD of the gut before and after Ruxo. So there was also recently published a survey in 19 centers across Europe, but also across the US, and they found 95 patients who were steroid refractory GvHD, either acute or chronic, and received Ruxo. And you can see the overall response rate was quite high, more than 80% in acute and more than 80% in chronic steroid refractory GvHD. So the problem using this is hematotoxicity, and also because of this immunosuppressive effect, also CMV reactivation. And there will be some new ongoing studies investigating Ruxo as a treatment for steroid refractory GvHD, either chronic or acute. So the transplant actually is now becomes more and more part of a package. So when you have patients who are considered to be a transplant candidate, so you should consider about so-called pre-transplant strategies before you go to transplant. So we have to reduce the spleen, because the spleen is a risk factor for so-called poor graft function. We have to consider to reduce the constitutional symptoms. The constitutional symptoms are a risk factor for non-relapse mortality. We have to improve the iron overload. So I didn't go too much into detail, but if patients are heavily transfused, so we should reduce the iron overload, and we should select the optimal donor. In the transplant setting, we should select patient according to the DIPS and maybe also to molecular markers more recently, and we should perform the conditioning according to the patient age and according comorbidity. There is no one fits for all regarding the conditioning regimen. But also, even more important, and this is not only for myelofibrosis, it's in all transplant settings, is we should look also for post-transplant strategies. So I've shown you we can monitor this patient very closely, because we have found now in all patients at least one molecular marker. So we can then consider early discontinuation of the immunosuppressant. We can give donor lymphocyte infusion, but also we have to consider JAK inhibition if there is severe graft versus host disease. So at the end, I would like to thank the members of my department from the EBMT, but also the others who are working closely with us to improve the results for our patients. So thank you very much for your attention.